We good to go? Okay. So, good afternoon, everybody, and welcome to Medical Grand Rounds. This is a very auspicious day because it's our first hybrid Grand Rounds, and it's our first time of switching Grand Rounds to noon by popular demand. So we'll see how that goes, but I'm happy to have at least some people here in person. So it's my great pleasure today to introduce Dr. Angelique Richardson, who to present Grand Rounds today. Dr. Richardson earned her MD and Ph.D. in microbiology and molecular genetics at Loma Linda University, where her Ph.D. dissertation was titled IGF-2 promotes estrogen-independent activation of estrogen receptors in basal-like breast cancer cells. I'm just going to take this off for now. She completed her internal medicine residency and chief residency at White Memorial Medical Center in Los Angeles, and her hematology and oncology fellowship at Penn State Hershey Medical Center. She then served on the faculty at the University of Miami. We were fortunate to recruit Dr. Richardson to UCSD, where she serves as assistant clinical professor and practices breast medical oncology. Her research interests center on cancer health disparities, serum biomarkers in the diagnosis and prognosis of breast cancer, and signaling pathways in breast cancer. She has published several peer-reviewed articles in these areas and was elected to serve the University of California as a member of the California Breast Cancer Research Council. She is the recipient of Early Stage Investigator Award support from the Moores Cancer Center and Hispanic Center of Excellence Faculty Development Award. She'll be speaking to us today on an introduction to cancer health disparities. Closing the gap takes a village. It's my great pleasure to introduce Dr. Richardson and welcome her to the first Grand Rounds of the year.
Thank you, Dr. Bork, for that introduction, and Dr. Jossel for the invitation. Everyone who was instrumental in inviting me today. Can you hear me okay? No? Okay. Sorry. I'll also try to speak up. Okay. Oh, okay. Okay. Oh, I think that's good. All right, thank you. And so, I'm also appreciative of those who came out in person. So it's nice to see faces after presenting for a couple of years on Zoom. And welcome to those who are here on Zoom with us as well. So I was asked to give a talk about cancer health disparities. And I want to talk about why it takes a village to close the gap. So I want to start on a very personal note. So my first introduction to health disparities was doing medical school. Came to medical school, I felt that, okay, I'm finally going to be in a position where I can help people. I can be the change that I want to see. I was really excited. And I felt like, okay, now this is finally going to be what I've been hoping to be able to do for so long. And then I started learning about health disparities. And I found out that Black men were at a highest risk of dying early from heart disease and stroke. And also that most of the major risk factors can be managed or prevented. There are risk factors like unhealthy diet, physical inactivity, obesity, diabetes, tobacco use. And as I learned more, I found out as well that Blacks compared to whites, they had disparities in outcomes. So Blacks were more likely to be hospitalized with complications from diabetes, to not have well-controlled glycemia or blood sugars. Their cholesterol, blood pressure were not well controlled. And for all, African Americans are more likely to die at early ages from all causes. And then it seemed like the list was exhaustingly long. There was breast cancer, 40% more likely to die from breast cancer. Also prostate cancer, twice as likely to die from prostate cancer. 3 times more likely to die from pregnancy-related complications. And it just seemed like, and this is a partial list that seemed to go on and on. And I said, well, what is it all about? Why and how is this happening? And more importantly, what can we do about it? Is it about health equity? Is it about health disparities? I was hearing these terms. I didn't know what these terms meant. Is it both? What do these things even mean? So some of the talking points today, I want to define, give some definitions for health disparities. Also to understand the determinants that impact health and contribute to these disparities. Briefly touch on concepts of race and ethnicity. I think when we have these conversations, we have to talk about it in that context. And review broad overview of health and cancer disparities. And also finally highlight some efforts that are aimed at addressing and eliminating these health disparities. So I'm going to start with some definitions. So the Department of Health and Human Services defines health disparities as differences in health outcomes that are closely linked with social, economic, and environmental disadvantage. And the CDC defines it as preventable differences in the burden of disease. And again, in socially disadvantaged populations. The World Health Organization says they are socially produced and unfair, thus they're modifiable and preventable deaths. So in summary, health disparities are differences in health outcomes between people of advantage versus disadvantaged backgrounds that are unfair or avoidable. You notice none of the definitions mention anything about race or ethnicity. It's simply about advantage versus disadvantaged backgrounds. And we'll get a little bit more into that during the talk. So many of us by now have seen this, either one of these pictures or both. And what this picture is showing is, we talked about health disparities, health equity. So if you look on the picture with the three individuals, you see that they're all trying to look over this fence to see this game that's happening on the other side. Equality is looking at the situation and saying, let's give them an equal opportunity to see over this fence. But what it's not taking into account is the fact that they all have different starting points. The individual in the purple shirt is still not able to see over the fence. And so equity is taking that to an account and giving them a little bit extra resource, a little bit extra boost so that they can have the opportunity for all of them to equally have access to seeing this game. And the picture on the other side with the two children is very similar. So inequality is the unequal access of opportunities. There's the one kid there with the red overalls, and he's basically standing there as this fruit just kind of falls into his hands. So equality is saying, well, let's give them both a boost, because this other kid with the blue overalls can't reach the fruit, but he's still not able to reach the fruit. And so equity is giving him a little bit of extra help to address that inequality. But actually what we all should be focusing on, or all should be aiming for, is justice. So justice is noticing that the system is bent, this tree is bent, correcting the system, and then giving equal access to opportunity. So both sides of the tree have equal amounts of fruit. And then that's the way that we can both see that everyone will have equal opportunities. So some common misconceptions that I've heard over the years are that health disparities only exist because of poor lifestyle choices. They're primarily due to genetic differences. And frankly, there's nothing we can do to address this problem, because it's either just too big or it's due to things that we can't change. So what are the causes of health disparities? So the factors are complex. They're complex and they're interrelated. And they involve many of the factors here, and this again is not an exhaustive list, but there's environmental factors, air, water quality. We've all heard about housing and redlining. There are some communities of color where there are highways and that are built right in the middle of the community. And so there are exposures to environmental exposures that happen in that way. There are food deserts where they don't have access to good, healthy food sources and spaces. And I have a personal story about this. When my grandfather was not doing well and my grandmother was diagnosed with diabetes, I said, well, you have to just change your diet. She had pre-diabetes at the time. I said, change your diet and eat more healthy foods and fresh foods. And he says, well, where am I going to get that when our closest store is this corner store? I grew up in Baltimore, and they did not have access to fresh fruits. And then the grocery store that was way across the other side of town, it was just way too expensive. And so these are real issues and then exercising, he didn't feel safe in the neighborhood. So there's those factors that we have to consider, cultural factors, someone's belief about wellness and illness. And there are also issues like clinical factors, access to healthcare, quality, healthcare. And there's psychological factors, there's stress, mental health, racism. And then there are other behavioral factors, tobacco use, diet, and physical inactivity, also adherence to cancer screening. So you can see that there is a list of things, and all of these things actually have to be addressed so that we can adequately eliminate health disparities. So I do want to talk about race and ethnicity and disparities research, because there's quite a bit of conversation that surrounds this. And these are some common definitions. I took these from the CDC, but these are also the definitions that I typically use when I'm talking about race and ethnicity. So for Black or African American, there are persons of Black racial groups in Africa, Hispanic, Mexican, Puerto Rican, Cuban, Central, South America, or Spanish culture. This is regardless of race, and I'll give an example of this later. White are peoples of European or North African or Middle Eastern, Asian, Pacific Islander, Far East, Southeast Asia, Indian subcontinent, or Pacific Islanders, and American Indian or Alaskan Native or original peoples of North America. And they maintain cultural identity through tribal affiliations or community recognition. So some of the questions that come about surrounding this topic isn't race a social construct? It was created by individuals to fit populations into categories. And if you are of mixed race, when I first presented, I was a graduate student and we were doing health disparities research, and a professor came up to me who I really respected, and then they asked me, well, if the person's of mixed race, what percentage qualifies them as one race or the other? Like, how did you determine in your samples that they self-identify as Black or white, and what percentage made them go into one category or the other? And so these are real debates and questions that people have. And isn't it true that there's no genetic basis for race? So race is a social construct. I like this definition. And a social construct is something that exists not in objective reality, but as a result of human interaction. It exists because humans agree that it exists. It's something has value because we give it value. And someone gave me the definition of like cryptocurrency. And so, because we say it has value, then now it has value. We agree upon the value that it has. So race is, one way to think about this is how someone self-identifies or how others identify that individual. So we may look at someone and say, okay, this individual appears to be a Black race, or this person appears to be a white race. But their ethnicity is identity based on their shared tradition, foods, language, and culture. So for example, Hispanic. So someone can identify as Black Hispanic, or someone can identify as white Hispanic. So these are some just really I'm giving a really high level kind of definition of these things. The completion of the Human Genome Project has created a lot of interest in this area of race and genetics. Because human nature is to try to fit things into categories. And we do want to create social constructs by structuring what we see and experience into categories. So for example, I have some pictures here of different mixed race families. And where do we say this person fits in this category or that category, and how much? And so you can see how it can kind of get really confusing very quickly if we just have like this, instead of thinking of it as a continuum, it's just these hard, fast categories or strict categories. So can race be found in our genes? I think we all agree that no, but there is a general consensus regarding race and genetics. So there is a thing that we would consider biological ancestry that can be found in our DNA. And this is typically passed down from generations. And that does tend to segregate along racial and ethnic lines because of shared social experiences and ancestry. And so a lot of the work that goes into the studies with health disparities and race is looking at some of these things with biological ancestry. So why is it important that we address health disparities? Okay, so we talked about health disparities and we talked about some of the things that can lead to health disparities, but why is it important to focus on it? Well, it's because it is influenced by social and systemic factors, and these things can be changed. And unfortunately, the biggest impact is on individuals who are already disadvantaged and carry a heavy burden. And it strains the healthcare system and economy. And really, it's just the right thing to do. So when we talk about the cost of health disparities, there is it's been estimated that the direct medical care costs for someone due to directly being affected by health disparities, it's about $230 billion a year. And then the indirect costs associated with illness and premature death is estimated to be more than $1 trillion. So addressing these health disparities is cost effective, but again, it's about equity and fairness, which is consistent with the values of our society. So I wanted to talk a little bit about COVID-19 and health disparities because I feel that there was attention that was drawn to more so recently to health disparities because of what was uncovered during COVID-19. I mean, I think most of us know that health disparities was definitely an issue way before COVID-19, but COVID-19 is something that really put a light on the topic again. We know that more than 1 million US deaths occurred during COVID-19, but not everyone was impacted equally. And so there were racial disparities shown in the COVID-19 data. So compared to whites, Native American and Black populations died at disproportionate rates. Here I put, it just shows over a timeline of racial makeup of the US population. But if you look at 2020 and 2021 is very similar. To give you an idea of the racial makeup so that when we talk about the next slide, you can put that in context. So American Indians or Alaskan Natives make up 0.7%, Blacks about 12%, Hispanic Latinos about 18-19%, Asian 6%, white population 57 or 58%. And this chart here shows that, this is from the CDC, it shows that Native Americans and Blacks, when you look at their proportion that they make up of the population, disproportionately higher rates of death. So it was 13% higher than their population shares for Blacks, or for Native Americans, it was 57% higher, which is really astounding. It's 57% higher. Native Americans died of COVID-19 more disproportionately than any other racial and ethnic group. And it decreased their overall life expectancy since the pandemic by 6.5 years. So their life expectancy is now 65 years, which is the same as many developing countries. Some of the factors involved, I just listed a few here, were poverty. They have the highest rate of any other group in the United States, 1 in 4. Discrimination and racism, exposure to polluted air and water, and also lack of access to quality care. I like this quote from Dr. Ann Bullock. She is a board certified family physician, and she is the director of the Diabetes Treatment and Prevention Center at this Federal Indian Health Services. She worked there since 1990. I think, I could be wrong, but I think she may have retired, but she's still very, very active. And she's a member of one of the Minnesota tribes. And her quote here was, "There's nothing weird or unusual about our population. This is simply what happens biologically to populations that are chronically and profoundly stressed and deprived of resources." So what about cancer health disparities? I talked some about general health disparities, COVID-19 health disparities. So I'll talk a little bit about cancer health disparities. So this is a list of US cancer health disparities at a glance, and I'm going to go into a few of these more in a little bit more detail, and specifically ones that are important for us being here in Southern California, some of the populations that we tend to see. So for Hispanics, they have a higher rate of liver and stomach cancer, but also a higher death. And these are in comparison to whites. Stomach cancer in Hispanic women, twice as high for Hispanic women, and incidence and death rate. So, and this is related to things like risk factors such as chronic infection with H. pylori. So Hispanics have a markedly higher prevalence of infection, 30% versus 9% for whites. And liver cancer in 2018, 1 in 5 individuals with liver cancer in the US were Hispanic. And their rates have increased by 4.7% every year since 2000. And this is very interesting because Hispanic men born in the United States have a liver cancer incidence nearly double that of men born outside of the United States. So just across the border. Diagnosed at, and they're diagnosed at more advanced stages of liver cancer. So some of the risk factors are higher rates of Hep B and C, liver cirrhosis, obesity, alcohol consumption. And there are major barriers that exist, such as access to testing and treatment. So we know that Hep C is treatable, but the treatment can be expensive. If you don't have insurance, then you are not likely to present for care or screening. There are language barriers, and also there's lack of access to culturally appropriate care. So for now we'll switch to Asian and Pacific Islanders. They have the highest incident rates of nasopharyngeal and lung cancer, about a 7-fold higher compared to whites. And this is frequently caused by infection with Epstein-Barr virus. And for Samoans, lung cancer incident rates are 4 times higher among men and women. And we think that this reflects the difference in the smoking rates in that population. So now I'm going to talk about Blacks and African Americans and some of the common cancers like breast and prostate. Black men have a higher prostate cancer incidence, 1.5 times higher, and their death rates are 2 times the rate of any other group. And breast cancer disparities, which is a particular interest of mine, there's similar incidence of breast cancer among Black and white women. So there was a time where I was able to say that Black women had a lower incidence of breast cancer, but unfortunately they had a higher death rate. But the incidence of, but that's not the case. So Black women are actually having a higher and higher incidence, reaching the same incidence as white women, but still they are about 40% higher risk of death after diagnosis with breast cancer. They're more likely to present at advanced stage. They're more likely to be less than 45 years old and to have a very aggressive form of breast cancer and very difficult to treat breast cancer, which is triple negative breast cancer. Black women have a higher rate of BRCA mutations. And so many of us know that BRCA1 and BRCA2 genetic mutations increase your risk of significantly increase your risk of developing breast cancer over your lifetime, as well as ovarian cancer. And in the US, it's been estimated that approximately 3 to 5% of women diagnosed with breast cancer have a BRCA1 and 2 mutation. But this estimate is based on research primarily done in non-Hispanic white women. When we look at Black populations in sub-Saharan Africa, there is a strikingly high occurrence of germline mutations, 5.6% for BRCA1 and 5.6% for BRCA2. And in Bahamian women, they have the highest incidence of inherited breast cancer due from BRCA mutations in the world, 23%. So if we look back at the comparison, that's 3 to 5% in the US with BRCA mutations. Ashkenazi Jewish women, which is where a lot of us say we focus on with BRCA and genetic mutations, they're 11%. But still, Bahamian woman, a Black woman who is from Bahamas, 23%. And then we don't even have to look in another country like Africa. We can look at Florida. We had a study that was done in Florida Cancer Registry at Black women who were diagnosed less than 50 years old, and they had a 12.4% mutation in BRCA1 and 2. And this was just looking through the Florida Cancer Registry and seeing how many of these women actually tested and were found to have BRCA1 and 2. And not many Black women actually undergo genetic testing. So these are the ones that actually were offered and went ahead and got testing. So how do we address these health disparities? Well, there are many ways to address it because all the different ways that we talked about that lead to health disparities, you can equally have a way to address it, but we need to address the social systems, right? It goes back to that picture where we talked about the justice, right? The lean in the system. These social systems allow for discrimination and racism to exist and be practiced in an organized fashion. So this is where health disparities arise. This is where they must be addressed. This is an issue that can be fixed. So that's important. This is an issue that can be fixed. So I want to kind of get a little bit at that point. So before coming to UC San Diego, I was at University of Miami under the mentorship of Dr. Mark Lippman and Dr. Judith Hurley. And I did a study with 2 other colleagues. And one thing that we knew was that there were disparities in breast cancer screening. We also knew that Black and Hispanic women had a lower rate of screening mammography than white women. And routinely, when they did come in, they were diagnosed at later stages, which are more difficult to cure. And then we also knew that these Black and Hispanic women were less likely to have insurance. And so they would present and seek care when the cancer is already at a later stage. So when the Affordable Care Act was signed into law in March of 2010, that led to an increased number of insured people. And in Florida, in the very beginning stages, already 1.3 million people signed up for health insurance. And so we wanted to look at before and after the implementation of the Affordable Care Act, if more women had insurance and if they came in with earlier stages of disease. So we did a retrospective chart review at Jackson Memorial Hospital, which is a safety net hospital in Miami. And so we looked at over 2,200 patients, and this was like I mentioned, a retrospective chart review. And we actually did not see a significant change in the stage of presentation after insurance. But when we did a further, we looked into this a little bit more, and we expanded our what we were looking at. What we actually found out was that more women who were previously did not have insurance, there was a huge increase in women who had insurance through the ACA. And these women were presenting at earlier stages. It's just that they weren't coming to Jackson anymore. They didn't come to the Safety Net Hospital. They now had insurance, and they were going to the other clinics in the area. So we were able to show that the installation of the ACA did allow these women who now had insurance to seek care at earlier stages. There were more stages of DCIS, which is highly curable stage of early cancer, than we had seen in previous years. And so this is a major implementation, because particularly in a time when we are addressing issues such as affordable health care and health disparities and health inequities. There's another study that I want to point out by Dr. Brent Rose, who's also one of our colleagues here at UC San Diego. They published a paper in Cancer. And some things that we know about prostate cancer, I mentioned in Black men that they are twice as likely to die from disease. I also mentioned that they present with more advanced stage. So the perception in the medical community among some, it was that Black men inherently must have more aggressive disease. So what they found in their study was that among patients treated in the US VA healthcare system, where all patients had equal access to care, Black men did not appear to have a higher death rate when compared to whites. So this was an observational study. They had more than 60,000 men with prostate cancer. It was a large nationwide database. And so they looked at patients treated from 2000 to 2015. 30% were Black, about 69 or 70% were white. The median follow-up was 7 years. Black men did not experience delays in diagnosis or care for their cancer. And the results were that Black men were no more likely to be diagnosed with more advanced or more aggressive cancer. And Black men were no more likely to die of their disease. In fact, what they found in their studies was that Black men were slightly less likely than white men to die from prostate cancer within 10 years of diagnosis. So, there's a lot of different caveats, and this obviously needs to be something that's looked into also outside of the VA population. But I think this brings up a very, very important question about access and about systems and care. So I don't want to make it seem as if I don't understand how complex the interplay of all the different factors are, as I mentioned earlier, and how they all intertwine to drive what we're seeing in cancer health disparities. And in fact, that's what led me to a collaboration with Dr. Hari Sharan. She's at SBP, or Sanford Burnham Press. And she had an interesting paper that was looked at DNA damage repair landscapes in Black women with breast cancer. So in ER, or estrogen receptor positive breast cancer, the mainstay of therapy is endocrine therapy. Once the cancer is no longer responding to endocrine therapy, or is what we call endocrine therapy resistant, then that leads to a poor survival and prognosis. And so what she found was looking at mutations of up and down regulation of these genes. She looked at breast tumor samples from normal patient samples, and then tumor samples in Black patients and white patients. And she actually found what she called DDR, or DNA damage repair signatures, that were unique in Black women that were associated with poor survival. And so this was also associated with cell cycle dysregulation, also a hallmark of endocrine therapy resistance. And so looking at that, we felt that this would be a great place to look and see this unique data set to investigate associations of other things like socioeconomic status, and look at that and see how that also correlates with these unique DDR signatures that we're seeing. And so her and I have written some grant proposals together, and hopefully this is something that we'll have more information about in the future. So I want to shift gears now to where do we go from here? So future directions. A big piece is, we need to further educate ourselves on health disparities. There's a broad range of topics that you can get involved in with this. So it can go from community engagement and outreach all the way to policy changes. So there are different areas of this that essentially anyone and everyone can find a piece of it where if they have interest, they can actually do something to address this issue. Part of it is establishing and building on community relationships and partnerships. So we need to expand the depth and the breadth of also educational opportunities, I think, to our healthcare providers, but also to our trainees to learn about community outreach and engagement. And because the importance of community outreach and engagement is partnering with the community. We want to assess what their strengths are and then work alongside with them to address their needs. And then that way we can build sustainable programs that are actually led by the community. So community-based interventions and engagement is what led me to getting to know that for the last couple of years, many of the patient advocacy groups. And so my main focus, like I had mentioned before, I am very interested in health disparities and breast cancer disparities with breast cancer in Black women. So Tiger Lily, Susan Komen, Many Shades of Pink were some organizations that I aligned with. And by doing that, I was able to, I'm still doing this work with them, but identifying community assets and utilizing community strengths. And there's a lot to learn from community wisdom. So you want to get involvement from all the key stakeholders, patients, community, researchers, policymakers, and it looks something like this picture here that has patients, survivors, caregivers, healthcare providers, academic, government researchers, biotech, pharma, policymakers, philanthropic organizations, and federal funding all coming together to address this issue because health outcomes, you can see in the picture that's in the diamond, it involves social economic factors, clinical care, behaviors, but also physical environment. So all of these things affect a person's health outcome. So for engaging community partners, you want to focus on building better relationships with the community because that allows for better exchange of ideas, information, and trust, and ultimately strengthening UC San Diego's community outreach and engagement to this underserved populations. So these are some of the examples, some things that I was very, very honored to be invited to do with Susan Komen, some presentations to the community. And Live Strong is a magazine that is targeted to Black women. So I was able to do an article for them, which was a great experience. And also on behalf of Tiger Lily, I also did an article in Cure. These two women are just amazing to me. They are both breast cancer survivors and they are CEOs of their own organizations. Tiger Lily is a local and nationally recognized foundation, and she does amazing work. Mayma, she's just a light and such a beautiful soul too. And so the work that she does, I am learning a lot from her. And Many Shades of Pink with Wendy, she is someone who is local and she's very, very deep roots in the San Diego community. And I've learned a lot about the San Diego community and the breast cancer and women with breast cancer just from learning from her as well. These are some of the health organizations, if you are looking on a government and level. So NIH, FDA, CDC, all of them are also very involved in doing different initiatives, all the way up, as I mentioned, to policy making and all the way down to just for research projects in each individual community. So this academic community partnership for health equity is where I think the answer to addressing the health inequities in our community. So we want to strengthen, we want to provide leadership in advancing health equity, but we want to support and promote the work of our community and assist them with finding their own solutions. And then hopefully it would be, I would like to see UC San Diego with community partners to be like this health equity hub and network for the community where it's a true partnership, where it's bi-directional. So, I'm always reminded that there are giants that came before me, and this is one of the giants in my mind. And I always am so honored and humbled by my ancestors that came before me to allow me to be here. And one of the quotes that I really like is, "Of all the forms of inequality, injustice in health is the most shocking and the most inhumane." And I think I have to agree with that. And so, another quote was, our lives end the day we become silent about the things that matter. I want to make sure that we don't forget the things that matter. And I want to thank everyone for listening. Are there any questions?
Are there other questions in here? Dr. Mandel.
Yeah, and so I'll have to, be honest about that. Dr. Hari Charan is the one, she really does that side of it. But her and I have spent a lot of time talking about it because I wanted to have a better understanding of what it is that we're actually seeing in the DNA and what we're actually looking for when her and I are working together to see what other outside stressors could be involved in that. And so, and I'll just say it the way that she's explained it to me. So what she is actually looking for, so she actually has a set, and this is actually from, most of her samples also came from the VA because there's a partnership that she has with them. And so they are matched normal samples with breast cancer samples from women who self-identified as Black or white. And what she did was she really looked to see if there were certain genes that were either upregulated or downregulated. And when she looked to see what was upregulated and downregulated and how amplified those actual genes were, she looked to see if there was a pattern or a signature pattern. And so if she said that there was and she showed me some of the pictures and like the heat maps, and there was a very distinct pattern in these genes with women who were who identified as Black. And not only that, but when she looked closer at those genes that were upregulated and downregulated, they were the genes that were associated with like cell cycle dysregulation, endocrine therapy, or endocrine receptor signaling. And so she's still interrogating a lot of that data and figuring more about it. I think we just scratched the surface of what we found there, but that's what she looked at, just upregulation, downregulation, what the pattern was there.
Any other question here? Dr. Parker?
One other comment, and I think Angelique has data. The breast group that you just participated in our platform trial. White women and other ethnicities have the same outcome.
Yeah.
Again, emphasizing the issue for some patients that if you create access and standardized management, outcomes can be equivalent. So doesn't apply to every situation, but certainly a model to aspire to.
Yeah, yes. Thank you for bringing that up because that was a topic that was at our recent breast conference. And yes, that's another really good example.
Hello. I have a question from one of our medicine seniors, and that's what stage are we at in terms of getting this embedded in UCSD breast cancer curriculum and on our boards?
Yeah. So that's a good question because I think a lot of attention is now also being placed on trying to get, and that one sentence I put in there didn't really speak to everything that I have to say about that. But when I said like more educational opportunities for trainees as well as us as healthcare providers, the thought that was the thought that I had behind that statement. And so I know that there is like the different accreditation bodies for the fellowships and the residency programs are really trying to push getting this information embedded in our training. And there's a lot of measures that they have regarding that. And I think it'll be a process. A lot of the low-hanging fruit is sort of starting with presentations like this one, and then maybe series where there's multiple presentations about it. And then eventually, hopefully, getting everyone to the point where even if they're presenting something about renal failure, that they're also talking about health disparities, or why is there a difference with this measurement, a test for this or for that, so that is hopefully where we're all going to, and I know it'll take time. But I think also from my experience, UC San Diego, they're also looking at that. I know I'm part of some of the different committees like JEDI and all of these other ones. They are looking at trying to get those things implemented. So hopefully a few years from now, this conversation will be a little different. Like everyone will say, oh, we know that we have this, and how could we still all continue to move forward? But I think we're working on it. It's just, unfortunately, progress happens a little bit slower than some of us would like, but it is happening.
So there's some questions on Zoom. So from Dr. Gass, since the lack of healthcare insurance subtends so much of the disparities cited by Dr. Richardson, one should be aware of those physician-directed organizations such as Physicians for a National Healthcare Program, PNHP, and its California spinoff, California Physicians Advocating for Universal Healthcare, CAPA. How does the speaker regard the roles of these organizations in policy change?
Yeah. So I'm going to be honest, I've heard of those organizations, but I don't know enough about them to say how they're involved in policy change. And so that's something that I will have to look into and educate myself. I do know that there are other organizations that are very involved in policy change, and a lot of them are patient advocacy groups. And they're always like a day on the Hill. And like I mentioned, Tiger Lily was one, but they just recently sent out information about, hey, let's get together, let's go to the Hill. We're lobbying for this, lobbying for that. I know Susan G. Komen has done that in the past as well. So a lot of patients are the big ones. And that's why I said sometimes just getting behind them and aligning ourselves with the momentum that they already have is really, I found it to be very beneficial.
Maybe you two can connect later to talk about that particular thing. Another comment and question from Dr. Temple. Great talk. What sorts of partnerships with biotech do you imagine being useful?
Yeah. So for example, so I've had someone from biotech the collaboration, and I'll give like, I guess, a very real example. So the project that I'm working with Dr. Hari Sharan and the signatures, she's already had some interest from biotech industry that is interested in finding out what these markers mean, and if there is a test that we can look at that would be better, or if we're making sure that the test that we are giving is taking into account all our patient population. So a lot of our testing that we have has not had a lot of input from diverse racial groups. And so the information that we're getting out, we're not always so certain if it applies to all the different women that we are actually seeing and treating in the clinic. And so there's a lot of interest from pharma and biotech companies knowing that, okay, are the tests that we have currently the best test for everyone? Or should we be including something else? Or should we have a test for this and for that? And so I see that there's a good opportunity for partnership there is an example.
So from Dr. Moore, this is incredible work. Do you have advice for those new to health disparities research on how to develop community partnerships and develop research questions? That's a big one. That's your whole career, but.
Yeah. So what I wanted, a big takeaway that I want hopefully everyone to get is that there's a lot of different ways to get involved in addressing health disparities in general, or cancer disparities. And so as I was mentioning, it could be aligning yourself with a group in the community that's already. What I did was I knew that I wanted to learn more about the Black breast cancer community. So I found out who were the key stakeholders in the community, who were people who were already advocating and people trusted already. And so I came to them, I didn't have an ask. I came to them and I said, can I just sit in on some of your meetings? Can I just listen? And I just sat there for a whole entire year or two and I just listened. And then eventually they would ask me questions. They would ask me to present. And so now that was my way of getting involved with the community. And honestly, like I was mentioning community wisdom, they actually told me the things they needed. And I found first the assets that they have, the things that they already have and they're doing very well, but then there are things that they need help with. And there's a project currently that's sprung out of that. I was volunteering at the Jackie Robinson Health Fair, and some women in the community were telling me that they had a lot of questions about genetic testing. And so they wished that we had a booth at their fair and that we could, so I was, I'm currently asking questions in our, with our leadership, like how we can, address these concerns and issues that these women have. So I think, just showing up, finding out who are the people who you're interested in, who are the ones that are already out there. These women are people that are already out there doing the work. Just align yourself with them and see, instead of us, I think sometimes we come in and we say, here's what I have, jump on board with this. And we forget to ask them, meet them where they are, and then to, like I mentioned, bi-directional. So we can learn from you just as much as hopefully we can offer you something that you can learn as well. But whatever we do, I think it needs to benefit the community. We can't just come in and say, hey, can you help me with this study? It has to be something that also benefits them.
Great. Seems to have generated a lot of interest here. The VA has shown, this is from Don Rubin, the VA has shown that providing universal health insurance and uniform treatment does make a difference in relationship to outcomes and disparity. Do you think these data from the VA indicate the failure of current insurance strategies pervasive in the rest of the population? And should the medical profession be more proactive in affecting change?
So if you ask me on a personal level, these studies, as well as the one that Dr. Parker mentioned from iSpy, it does, that information does seem to show that if we allow people to have equal access to care, then we can definitely do something to address the survival and outcome disparities that we're seeing. So, that's where we start to go kind of to like the policy level and implementing those changes. I definitely think that if at the very basic level, we should at least try to make sure that people have access to good quality care in whatever way that may look like, trying to put in systems in place that people who, whether they have insurance or not, they have somewhere that they can come and still get good quality care.
Okay, one more from Dr. Mark Fuster. Lung cancer is another malignancy with what seems to be growing disparities in access to low-dose CT screening and also disease outcomes. Is there work being done in the area of how socioeconomic disparities may impact stage and mortality data, much like your exciting work integrating this question into basic biological discoveries in breast cancer?
Yeah, and I wasn't able, so that's another good point to bring up about lung cancer, and that's exactly correct. With having access to low-dose CT scans and the work that's already been shown that doing those in the appropriate population can help find lung cancers earlier at a more curable stage. And for those individuals who don't have access to that, then we know that they will be missed. And so there is work that is being done in that area too. And so, whatever sort of area that you are interested in, you can look into it and find that there are different groups that are working on that. Definitely there's a lot of work that's been going into that, but there's a need for more work into that and more people interested in it.
Okay, thank you. Any other questions here?
Just a couple of comments. These are wonderful discussion items. Is that always think about your databases. If you're collecting data on patients, on students in a non-healthcare environment, you always want to think about the diversity of that population, because if you're training then on the basis of that data set, if that data set is not diverse enough to be representative of your population, then training on that data set is going to bias your observations and bias any analysis that you can perform. Same thing in the artificial intelligence area. There have been some well-publicized situations in which AI was trained on more homogeneous populations than heterogeneous populations, and then were very incorrect in recognizing different racial individuals. So one has to really be thinking about health disparities and race and ethnicity and all the work we do in healthcare.
Mhm. Yeah.
Thank you. Any other questions from here? I have one also related to the DNA damage response. Is that known as in other cancers as well, or is that specific to breast cancer? And does your collaborator perhaps have a hypothesis as to what might be causing that? I find it fascinating.
Yeah, yeah. And she actually will probably, so hopefully I can also get her to come and do a whole presentation on that, because the work that she does is very fascinating, and her and I have spent so much time talking about it. Every time we talk about it, I learn something new. And so my understanding is that from reading up a little bit more on it and talking to her, there are similar signatures found in other tumor types as well. And I can't say too much more about those because I don't know a whole lot more about it, but I do know that what she's seeing is something that has been seen in other places as well. And then the other question you had was,
If there's a hypothesis as to what might be
her
causing that.
yeah. So we don't really know exactly. And that's sort of why her and I wanted to look into other things that maybe we haven't looked at before that can explain it, because her and we both feel that a lot of times this work is done in isolation. So either we look at like the social economic factors and how that affects things, or we look at the genetic factors. And we know that for a few people who look at both, that there is, and you can't really separate those two things. So the reason why we want to look at those together is because we feel that there might be something there that can help us answer why we're seeing what we see. So we don't know. She does have some different hypotheses, but they're all just sort of speculation. We're still trying to figure it out.
Great. So I think that's it for the questions. I want to thank you for a very insightful and educational grand rounds, and for stimulating a lot of conversation and discussion. And hopefully this will extend to other areas and spark a lot of interest in other people to pursue this. So thank you very much.
Thank you. Oh, okay.